Next subject. The subject is liver disease in general and cirrhosis. Next subject, the subject is liver disease in general and cirrhosis. So therefore, let us say what all things that cause cirrhosis, what do they all have in common? What do all things with cirrhosis have in common? They all are caused by fibrosis of the liver. What do they all have in common? They all are caused by fibrosis of the liver. So all things from cirrhosis, where the word for the rock comes out of rock or stone, skiros, for stone-like, because that's what your liver becomes, a stone-like fibrotic nubbin that doesn't do anything, because all the cells are dead and have been replaced by fibrous tissue, by fibroblasts, and by fibers in that tissue. So no matter what the etiology is, cirrhosis of all kinds is going to cause a decreased albumin. No matter what the etiology, cirrhosis and its symptoms is based on the severity. It's not the etiology, it's based on the severity. You'll hear that before. The low albumin leads to edema. The low albumin can help lead to ascites. The low albumin can lead to edema and ascites. So therefore, the low albumin is one of the causes of the edema and the ascites. The cirrhosis can lead to an elevation of the prothrombin time because all clotting factors in the body are made in the liver. All the clotting factors are made in the liver with the exception of factor 8. And von Willebrand's factor, yeah. Von Willebrand's factor is made in the endothelial cells. Von Willebrand's factor is made with factor 8 and stored in subendothelial cells in the vasculature. Prothrombin time. Well, even if the prothrombin time is elevated, we don't do anything about it except if you are bleeding. If you are bleeding, then we give fresh frozen plasma. If you're bleeding, we give fresh frozen plasma because vitamin K will not be effective and takes too long. Not be effective, vitamin K, and takes too long. One, not effective because if the liver was working, we wouldn't have a high prothrombin time to begin with. Second, even if it might work, it takes too long if you're bleeding. We need to reverse it immediately with fresh frozen plasma. Low albumin states making the edema and the ascites. The treatment for the low albumin states leading to edema and ascites, the specific therapy for the edema and the ascites of fluid retention from cirrhosis is spironolactone. Now, spironolactone is because the edema leads to intravascular volume depletion. Your juxtaglomerular complex and macula densa make increased renin, increased angiotensin 2, aldosterone. So it goes from renin to angiotensin 1 to angiotensin 2 to aldosterone. So therefore, all patients who have cirrhosis have high aldosterone states, and spironolactone inhibits the effect of aldosterone. Therefore, with the high aldosterone state of a person who is cirrhotic, aldactone, which is to say spironolactone, is the drug of choice because it inhibits that aldosterone. Now, what else do all people with cirrhosis have? They don't make albumin. They don't make clotting factors. They get various annoying skin things like spider angiomata like palmar erythema, spider angiomata, palmar erythema. They can get things like asterixis, which is a liver flap, an asterixis, where people are going, hello, can you say hello? Hello, hello. Flap, 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 flap. Oh, not good. Okay, ooh, my GABA's upset. Ooh, my neurotransmitters suck. Ooh, I've got too much accumulation of the worst neurotransmitters, and I'm flap, 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 asterixis. Is he waving bye-bye? No, I can't. Yeah. Asterixis. So, all people with cirrhosis get ascites, they get edema, they get high porthrombin time, they get increased portal hypertension. They get encephalopathy. Now, the portal hypertension can lead to varices. And if you have varices, you bleed. If you bleed, we band. If you bleed, we band. If you bleed, we band. A rubber band in the esophageal varices? Damn right. Better than sclerotherapy. Better than surgical shunting. Better than a Blakemore tube is banding. Crawl down your throat and put a rubber band around your esophageal varices. Yup, it's a lot better than bleeding to death. If you bleed, then you band. If you haven't bled, or to prophylax the next bleed, as prophylaxis against the next bleed, we give beta blockers. Beta blockers. We give beta blockers. As prophylaxis against the next bleed, we give beta blockers. So, you bleed, you band. You prophylax, you give beta blockers. Varices. Encephalopathy, to treat and prevent the encephalopathy is managed with lactulose. Well, encephalopathy from cirrhosis from which etiology? Cirrhosis from alcoholic cirrhosis? Is it going to be from alcohol that you're going to give that lactulose? Is it going to be from chronic hepatitis B and C that you're going to give that lactulose? Is it going to be that you're going to give lactulose for the encephalopathy from alcoholic cirrhosis? Is it going to be that you're going to give lactulose for the encephalopathy from primary biliary cirrhosis or from alpha-1 antitrypsin deficiency? Is it that it's going to be from the cirrhosis from alpha-1 antitrypsin deficiency from chronic hepatitis B and C? Is it going to be for the cirrhosis from Wilson's disease or from hemochromatosis? That word's longer than it used to be. I don't remember that word being that long. That word got longer just this morning. I used to have more room to put that word in there. I swear to God, that word only had like 4 letters in it just yesterday. Hemochromatosis, I swear, it's a much shorter word. Just yesterday, I could fit that in. It's like a 4-letter word yesterday. It only got to have that many letters just sometime this morning. It grew. The cirrhosis from whatever etiology it is, gives all of these things because they can all lead to fibrosis and obstruction of the portal circulation. 2/3 of the blood to the liver is from the portal vein. It's one of the only organs in the body of which the predominant blood supply is a vein. The blood going into it is a vein. Low flow, low pressure. If it's normally low pressure, that means fibrosis or obstruction can prevent the flow of blood into it. It's one of the few things. It's not like a brain, which is an arterial supply. These things, my carotids and my vertebral arteries back here, have high pressure. If you'd cut my head off, the blood would shoot up to the ceiling and would shoot up to the next floor. However, the vein flow of the portal vein is low flow and low pressure. Therefore, as the liver fibroses up, you will be much more susceptible to backflow problems. backflow into my portal circulation, backflow into my varices, backflow and causing ascites and edema and big liver and big spleen, big hemorrhoids, big spleen. And when you have an elevated spleen, why? You have a problem with low platelets. But don't transfuse platelets unless they are bleeding and have a platelet count less than 50,000. With bleeding less than 50,000, you will transfuse the platelets. Don't transfuse unless they're extremely low. That's just part of the condition of the disease. Second of all, if you're not bleeding and the platelet count is 22,000, what are you going to do? Transfuse platelets? Well, every 6 hours for the rest of your life? Well, it's not going to get better. If you're not bleeding, don't transfuse. Part of the hypersplenism is everybody gets a low platelet count. That's just part of the deal. Lactulose is superior to neomycin. Lactulose is superior to neomycin. Neomycin is a non-absorbed aminoglycoside antibiotic. Neomycin is a non-absorbed, not absorbed, aminoglycoside antibiotic. So therefore, if the neomycin is given, it kills the bacteria that cause the increase in ammonia. Ammonia encephalopathy. Now, everybody will say, well, it's not just ammonia. That's true, it's not just ammonia. However, if you treat ammonia, you can improve the encephalopathy. And besides that, what else do we know to treat? Lactulose and neomycin treat the things that we can identify at least. This is what everybody with ascites gets, portal hypertension, edema, ascites. And this is how you treat them in general. Now, the whole point of checking the ascites and to see what the albumin level is the albumin level is low in portal hypertension. The albumin level is low in portal hypertension. The albumin level is low when you have portal hypertension. The albumin level is low in the portal hypertension. So if the albumin level is low in portal hypertension, the difference between the serum and the ascites, the difference between the serum and the ascites level of albumin, the difference between them, if the level in the ascites is low, the difference between the serum and the ascites will be great. So the difference between them. Well, why don't we call it a serum to ascites albumin difference? A serum to ascites albumin difference? Because that would be abbreviated as a serum to ascites albumin difference. Now, gastroenterologists are fundamentally happy people. You got to have a good sense of humor to spend most of your day crawling through people's anuses and spending all day long looking at stool in the colon. So they're fundamentally, I think, relatively happy, chipper people. So they didn't want to call it a serum to ascites albumin difference. That would be a SAD. Did you check the SAD? Oh, they have a high SAD. Oh, they have a high SAD. Well, that's sad. No. Well, they're happy people. So instead of calling it a serum to ascites albumin difference, it's called a serum to ascites albumin gradient. And the serum to ascites albumin gradient, a SAG, at least it sounds like it's a lot more cheerful than saying the SAD for people. We leave all the unhappy acronyms to the hematology oncology people who are chopping and mopping and cop-blamming and cytobombing and all the other bad acronyms. The SAG is increased when you have portal hypertension. The gradient is increased because the level in the ascites is low and the level in the serum is higher. So the gradient or difference is increased, greater than 1.1. In other words, if the ascites fluid was the same or high, the same as the serum, the gradient would be low. Low gradients between the serum to ascites albumin gradient being low is things like cancer. Cancer gives a low gradient because cancer puts more protein and albumin into the ascites. Portal hypertension gives a high gradient, a greater difference, because the amount of albumin in the ascitic fluid is lower. And that is the fundamental difference. Hey, I got a big belly full of ascites. What's that from? Well, I don't know. It could be everything from Meigs syndrome to portal hypertension, cancer, tuberculosis. It could be hypothyroidism. It could be albumin losing, malabsorptions in the gastrointestinal tract. It can be all kinds of things from TB peritonitis, secondary peritonitis, spontaneous bacterial peritonitis, portal hypertension, hepatoma, peritoneal carcinomatosis, ovarian cancer, pancreatic cancer, colonic cancer. Ooh, too much information going through my brain. Too much information driving me insane. Oh! All of the cancers have high albumin levels, and the SAG will be low with cancer. All the things that cause portal hypertension, such as all the many forms of cirrhosis, will give a high serum ascites albumin gradient, which is to say portal hypertension, and the SAG will be high. And that's the difference. Now, the SAG does not tell you necessarily while you have infection. Some infections will have a high one, some a low one. Secondary peritonitis, in other words, I got a hole in my belly, I perforated something, TB peritonitis, give a high albumin, which is to say a low gradient. So certain infections will go here. Spontaneous bacterial peritonitis will go here because in spontaneous bacterial peritonitis, there is a low albumin level. A low albumin level. So spontaneous bacterial peritonitis will go here, and spontaneous bacterial peritonitis is fundamentally based on whether or not you have a high number of white cells. Greater than 500 white cells, SBP. 500 white cells or greater than 250 total neutrophils. And that will mean it's time to give the cefotaxime or ceftriaxone. Cefotaxime or ceftriaxone if the person has spontaneous bacterial peritonitis. The organism is E. coli. What causes it? Well, the organism is E. coli. But why do you get the E. coli? I don't have E. coli in my peritoneum. Why do they get E. coli in their peritoneum in spontaneous bacterial peritonitis? Why? It's spontaneous. Oh, chipper, happy. Sounds like we're having a party. What should we do in the peritoneum? Let's have a spontaneous bacterial peritonitis party. Well, how are the bacteria going to get in there? I don't know. It's spontaneous. Did you send out an invitation? What, you mean like a perforation, a gunshot wound, a duodenal ulcer, a perforated appendix, a perforated diverticular abscess? Did you send out an invitation like an ulcer disease that's in your duodenum, ulcer disease in your stomach, appendicitis, or diverticular rupture? Did you send out an invitation? Oh no, it leaked through. It's spontaneous. Do you mean idiopathic, such as you have no damn idea how it happened? You don't know how it happened, did you? You don't know how those bacteria got in there, do you? Well, no, not exactly. Well, why don't you call it idiopathic, such as you don't really know? Oh, I couldn't say that. I'm a doctor. I'm the top 1% of all people in the world in education, knowledge, income, experience, social potential. I couldn't actually admit that I didn't have any real idea why the disease occurred. I can't say I don't know. It's spontaneous. It happens. Oh, sometimes bad things happen to good peritoneums. Oh, that's poetic. Sometimes bad things happen to good peritoneums. Spontaneous. It leaked through. Well, if it leaked through, how come there's no anaerobes if it's leaking through? Huh, there, stud muffin? If you're so smart, how come the anaerobes, which are filling up your colon, are not leaking through either? Well, we don't like them. You don't like them? That's the reason? All right, I don't know why. All right, I admit it. All right, I admit it. I admit I don't know why the anaerobes don't go through and the E. coli does go through. Why do you get pneumococcus in there? Are the lungs in the bowel? Oh, don't be so insulting. You know the lungs are not in the bowel. Then why do you get pneumococcus? Why do you get pneumococcus? I don't know. You're only as sick as your secrets. Just admit it. You get pneumococcus and you don't know why, even though pneumococcus is not in the bowel. You don't get anaerobes and you don't know why. You do get pneumococcus, which should be in the lungs. Otitis, sinusitis, bronchitis, pneumonia. But you get pneumococcus. You don't get anaerobes, which are packing the bowel. Why? I don't know. But you do get E. coli, and that's understandable because that is in the bowel. How do I determine that there's spontaneous bacterial peritonitis? I test the acidic fluid. Boom. And I see greater than 500 white cells or 250 neutrophils. Cefotaxime, ceftriaxone. Why cefotaxime? Because cefotaxime and ceftriaxone have the same spectrum of organisms as each other. They are identical. Cefotaxime, ceftriaxone treat the same bugs. But cefotaxime is renally metabolized. Renal? You mean kidney? Yep. And ceftriaxone is hepatically metabolized. Therefore, for people who have dead liver, giving a hepatically liver metabolized medication may not be perfect. Although it does cover the organisms, giving a hepatically metabolized medication is not ideal. Cefotaxime is the drug of choice for SBP. I have ascites and pain. Tap. New ascites. Tap. Ascites and fever. Tap. Ascites and tenderness. Tap. Ascites and pain. Ascites and tenderness. Ascites and fever. Each a tap, 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 tap. 500 white cells, cefotaxime, and it's irregardless of the etiology. People who have low albumin levels in the acidic fluid are going to have a high gradient, and the SAG is above 1.1. The SAG, the serum ascites albumin gradient, is really only good for one thing, to diagnose portal hypertension. And all the patients, no matter what the etiology is of their cirrhosis, all of the patients can have a high SAG if their portal hypertension is bad enough. Now, this is what we're talking about for all patients with cirrhosis in general, not particular to any one of these etiologies. Now, that means that primary biliary cirrhosis can do it if it's severe enough. It's not the etiology, it's based on the severity. It's not the etiology, it's based on the severity. Primary sclerosing cholangitis. Primary. Well, what causes the primary? Well, it's associated with inflammatory bowel disease. Yeah, but what causes it? Well, it's primary. Well, what does primary mean? It means idiopathic? Basically, yeah. Please refer to spontaneous discussion. Well, why sometimes do we call it spontaneous and other times we call it primary? These mean that you get biliary cirrhosis and you don't know why. You have an itchy, pruritic, itchy, middle-aged. What does middle-aged mean? Anybody who's slightly older than me, of course, which is mid-40s to 50s, 40s and 50s. Middle-aged female, an itchy middle-aged female with an elevated isolated alkaline phosphatase. Elevated alkaline phosphatase in an itchy middle-aged female. Well, what causes that? Well, it's primary. Oh, primary you mean idiopathic. Yes, that's right. When we don't know what something is caused, instead of saying, I don't know, sometimes we call it spontaneous, sometimes we call it primary. And sometimes, if we really want to screw you up, and you have a lifelong disease, and we don't know why, we tell you it's essential. What do you mean we tell you it's essential? That would mean like, you gotta have it. Right. Hypertension, the most common disease in the country. 60 million people in the United States are defined as having hypertension, which I can make more happen anytime if I lower the cutoff for hypertension. But essential hypertension, what causes it? The most common disease in the country. The most common risk factor for the most common cause of death in the country. What causes it? Ooh, it's essential. You gotta have it. You gotta have it. Essential tremor, what causes that? Idiopathic. Essential hypertension, what causes that? Idiopathic, we don't know. Essential thrombocythemia, platelet cancer, what causes that? Idiopathic. So when we don't know what causes something, we either call it spontaneous, primary, or essential. What causes this? It's an autoimmune phenomena against the biliary ducts. It's associated with other autoimmune disease in women who are in there above the age of 40, 50, middle-aged women with an elevated alkaline phosphatase. That is what's supposed to tell you that it's time to get the anti-mitochondrial antibody. How do I know to get the anti-mitochondrial antibody? Well, I get a person who's an itchy middle-aged female with an elevated alkaline phosphatase. And the sonogram shows nothing. Oh, the CT shows nothing. The hepatitis B and C serology, the hepatitis B and C serology testing is negative. The hepatitis B and C serology, the surface antigen for hepatitis B, the E antigen, the surface antigen, are all negative. The hepatitis C antibody is negative. And when you have the hepatitis B and C antibody testing that are negative, then you have a person who, well, they're not an alcoholic, the hepatitis B and C are negative, and is an elevated alkaline phosphatase. And that's what tells you to get the anti-mitochondrial antibody. Now, primary sclerosing cholangitis should be suggested by the fact that the person who also is a person who has an elevated alkaline phosphatase as well here, but has evidence of jaundice and elevated alk phos in a person with inflammatory bowel disease. Now, all biliary obstructions can cause an elevated alkaline phosphatase. All biliary obstructions can cause an elevated alkaline phosphatase and an elevated gamma-glutamyl transferase, GGTP. But in inflammatory bowel disease, Crohn's and ulcerative colitis, it's not whether it's Crohn's and ulcerative colitis, it's how long has there been the duration of involvement of the colon. The colon's inflamed. The portal vein is made up of the superior mesenteric vein and the splenic vein. And my inflamed colon is sending inflammatory mediators up into my liver. Slow cooking and baking and basting my liver in inflammatory mediators. Kind of like making beef jerky. Slowly drying out and fibrosing up that liver. Woo-wee! We got some great jerky. We got regular, teriyaki, and liver-flavored sclerosing cholangitis, chronically slow-cooked liver here with sclerosing cholangitis, those inflammatory mediators coming off of the colon, sizzling and basting up and making beef jerky out of your liver. Over 10 years. It's not whether it's Crohn's or ulcerative colitis, it's whether or not your liver is getting slow cooked and basted and dried out and cured by the inflammatory mediators coming up from the colon. Now we have something unique here. primary sclerosing cholangitis is the only one of the causes of cirrhosis that is not most accurately diagnosed by a liver biopsy. Hup! Liver biopsy is the most accurate test. Liver biopsy is the most accurate test. Liver biopsy is the most accurate test. Which of the following is the most accurate test? Liver biopsy. However, the test most likely to lead to a specific diagnosis is the liver biopsy. Huh? Most accurate test, liver biopsy, except for this one, which is the endoscopic retrograde cholangiopancreatography. Endoscopic retrograde cholangiopancreatography is the single most accurate test looking for tortuosity and beading. Beading? Bleeding? Not bleeding. Bead, as in beads. Beading of the biliary system and the tortuosity and beading found on endoscopic retrograde cholangiopancreatography. Put a scope inside and put some contrast material into me. By squirting the contrast up into the biliary system, I'm able to see the tortuosity and beading of that biliary system, which is the most accurate diagnostic test. When looking at the biliary and pancreatic ductal system, the single most accurate test is endoscopic retrograde cholangiopancreatography. Now, both of these are treated in the same way. Both of these are treated with cholesterol and bile acid binding resins. Cholestyramine or ursodeoxycholic acid. Ursodeoxycholic acid, which is bile acid binding resins and inhibitors. For both of these, urso and chenodeoxycholic acid dissolve up that bile, make it more lipid soluble and get it out, and cholestyramine bind it in the bowel. Bind it in the bowel, urso and chenodeoxycholic acid. Derive it from a bear, Ursa major, Ursa minor. I do not want the constellations any nearer. I know they are very well where they are. Ursa major, Ursa minor, deoxycholic acid, derived from a bear's liver. Now, the management of hemochromatosis and Wilson's disease, well, how are we supposed to know the hemochromatosis or the Wilson's or the alpha-1 antitrypsin deficiency are there? Well, we have in chronic hepatitis B and C a very nifty blood test. We have chronic hepatitis B when we see surface antigen or E antigen. We have chronic hepatitis B when we have surface antigen, or we'll see the E antigen, E for early antigen. An interesting thing to see E or early antigen for chronic disease. I see the early antigen for chronic disease. Well, it's persistence of the early antigen. Well, we have a nice nifty blood test here for chronic B and C. Greater than 6 months, greater than 6 months of surface antigenemia. Greater than 6 months of surface antigenemia tells us that we have chronic hepatitis B. But the most accurate test is always a liver biopsy. We have hepatitis C antibody, but the most accurate test is a liver biopsy. Well, we have a great test here to tell you. Well, we have a test for alpha-1 antitrypsin deficiency, and that's called getting a level of alpha-1 antitrypsin. The question is not just whether you should get the test, it's what will be in that history and physical to distinguish it from all of the others, A, B, C, D, E, F, G. What's going to be different in there to tell you to get the level of alpha-1 antitrypsin? Maybe we should get a ceruloplasmin level. A decrease in my cerulo, which is a $5 word for copper, ceruloplasmin, the plasma level of the cerulo or copper-carrying protein. Why shouldn't we get a ceruloplasmin level? Why shouldn't we go chasing the iron studies with an increased iron level, an increased ferritin level, or a low TIBC, total iron binding capacity? Why should we get the alpha-1 antitrypsin level? What's different? This disease in the history will have portal hypertension. No, that's all of them. Ascites. No, that's all of them. Edema. No, that's all of them. Big liver. No, big spleen. Big spleen. Edema. Ascites. No, no, no. Asterixis. Hello, hello. No, that's all of them. What's different about that disease? One word difference, lung disease. Lung disease. This is the only one that has lung disease. Emphysema, the young non-smoker with a family history in emphysema. What's different is we have the lung disease. We've got a lung emphysema. Young. Why should you be having emphysema at 45? Whew. 41 is practically pediatrics. So why should you have lung disease at the age of 41? Because it's not from cigarette smoking. A young non-smoker with lung disease and emphysema, alpha-1 antitrypsin. Alpha-1 antitrypsin, I wouldn't want to have it, but it's easier than the others to diagnose. It's the only one with emphysema. You get a low level, and the treatment is simply to replace the enzyme, to replace the hormone, to replace the enzyme that will prevent the progression of the lung disease. It just replaces the enzyme. Now, what's different about these, different from the others? Why should I get a ceruloplasmin level? Why should I see an elevated iron, elevated ferritin, low iron binding capacity? The capacity is low because the body is packed with iron. So if it's packed with iron, there's no capacity. All the seats are filled in this room, there's a low capacity. The seats are empty, there's a high capacity. It's exactly the opposite of iron deficiency anemia. Hemochromatosis is the most common hereditary genetic disease in the GI tract. It's enormously common to have the overabsorption of iron. You can only use about 2 or 3 milligrams a day of iron. Even if you're pregnant, you only need 5 or 6 milligrams a day of iron. So if you're absorbing much more than that, how do you naturally excrete iron? Come on, show me how you excrete iron. Come on, come on. How do you normally excrete iron? Stool. 50% of the volume of your stool is cells from the gastrointestinal tract. Therefore, the only natural way to excrete iron from the body is to lose cells. You menstruate, you desquamate. You menstruate, you desquamate. Lose skin cells. You menstruate, you desquamate. Loss of squamous, desquamous. Are you losing cells? Yes, I am desquamosing today. And stool. Well, unless you sit around with sandpaper, you can't remove more iron from your body. So if you're over-absorbing it in the bowel, you can't get rid of it. It's not like the kidney. Hey, you drink an extra 3 liters of Diet Coke, don't worry about it, you'll piss it out. Had too many salty pretzels, don't worry, you'll piss it out. Too much potassium, too little potassium, your kidneys will regulate it, bang! And even acid base, it will regulate over a day or two, 3, 4 days for sure, you've regulated your kidney and acid base. But what about iron? There's no naturally good way to increase iron excretion. Try it right now. Try it right now. Okay, break. We're taking a break. Everybody sitting and watching this tape is now going to increase their iron excretion. Scraping with sandpaper? Maybe you should start menstruating today. Increasing iron excretion. Nope. There's no natural way to do it. So if you are over-absorbing iron, your body can't compensate by just excreting more, not like the kidney. So hemochromatosis, the iron starts to build up. It starts to build up in the liver and causes cirrhosis, 60%, hepatoma, 20%, into the heart, and you develop restrictive cardiomyopathy. You remember restrictive cardiomyopathy, right? Sarcoid, amyloid, hemochromatosis, cancer and fibrosis. Sarcoid, amyloid, hemochromatosis, cancer and fibrosis. The Causes of restrictive cardiomyopathy. It starts to build up in your joints and you cause arthralgias in your pancreas and you get diabetes with skin changes. So-called, my favorite, bronze diabetes. Bronze diabetes. And you get teensy weensy little useless steel testicles as the iron builds up and gives you little iron raisins for testicles and builds up in your pituitary and you don't make FSH and LH. Infertility, bronze diabetes, joint, it builds up in your joints, builds up in your pancreas and you get diabetes, builds up in your liver and you get cirrhosis and hepatoma, builds up in your heart for restrictive cardiomyopathy, sarcoid, amyloid, hemochromatosis, cancer and fibrosis are the causes of restrictive cardiomyopathies. That's how you know to chase the hemochromatosis. The most common cause is the genetic overabsorption of iron in the duodenum. When you manage to get it, you treat it with phlebotomy. You treat hemochromatosis with phlebotomy if it's from overabsorption of iron. If it's from chronic hypertransfusion, aplastic anemia, myelofibrosis, myelophthisis, dead marrow, aplastic anemia, myelodysplasia, myelophthisis, which is a myelophthisis, sort of a 19th century word. Phthisis, phthisis, P-H-T-H-I-S-I-S, phthisis. Well, now we know why it was changed to myelofibrosis, so we don't have to go around. What do you got? What have I got, doc? You got myelophthisis. Thank you. But what have I got? Myelofibrosis. Oh, thank you. Myelofibrosis, overtransfusion. Tuberculosis in my marrow, myelodysplasia. Those people who get overtransfused from fibrosis or aplastic anemia or myelodysplasia, those people get treated with deferoxamine. Those people get treated with deferoxamine because you can't do phlebotomy. Hey, what are you going to do for me? Deferoxamine or phlebotomy? Well, I've overabsorbed iron. Phlebotomy. Phlebotomy you? No, phlebotomy. Get rid of that iron. Deferoxamine is for people who get overtransfused. That's how you know to test for the iron studies and do the phlebotomy with overtransfusion leading to all of these things. What is unique about Wilson's? Have you ever sent a ceruloplasmin level in your whole entire life? No, I don't think so. Don't even pretend. I know you're trying to curry favor and get me to like you by saying, yes, I sent a ceruloplasmin once. I'm cool. But you've never sent it because you never had a reason to send it. You never had a reason to send it. So what should tell you to send it? Oh, I know what you're thinking. You're going to look for the Kaiser-Fleisser rings in the eyes. But the Kaiser-Fleisser rings need the slit lamp. Most of the time. They're sometimes visible with the naked eye, but most of the time they need a slit lamp. Well, how many slits have you looked at in slit lamp examinations? Not too many. What would tell you to get that? Not Kaiser-Fleisser rings. If they say, guys got Kaiser-Fleisser rings, that will tell you. Now, they're not visible on general examination most of the time. You need a slit lamp to look for the deposition of copper in Descemet's membrane. Poetic, Descemet's membrane. But you need a slit lamp. What will tell you? Is there anything different about Wilson's, different from the other ones of these diseases? Well, primary biliary cirrhosis had an itchy middle-aged female. Chronic B&C had a nifty serology. But what's different about Wilson's? Is there anything that might grab you on physical examination or history that might tell you on physical that make it obvious? Could it be that Wilson's, well, let's see what's obvious here. You got lung disease, but about Wilson's, how would you ever know? Would it ever stand out? Is there anything that would draw your attention to the Wilson's disease different from the others? Why a movement disorder? Yes, it's true. A choreiform movement disorder. Though they didn't do this in your medical school? Well, if they did, you would remember it. Because the part of the human mind that can remember word and text, the written word, is relatively limited. but the part of the human mind that can remember gesture. Wilson's and psychosis. Movement and psychosis, movement and psychosis. The part of the mind that can remember word is less capable than the part of the mind that can remember movement, tone, smell, gesture. Movement disorder and psychosis. What's different about Wilson's? Movement and psychosis tells me that I should look for those Kaiser-Fleischer rings with a slit lamp examination and get the ceruloplasmin level. Don't answer steroids because steroids don't work, but penicillamine will work. Penicillamine to help with the over-deposition of copper in Wilson's disease. What we have done here is that we have given you something unique about each one of these. We treat the chronic hepatitis B with interferon or lamivudine. Now we have to be careful of this part because this is the part that's liable to change sometime in the next year or two. So I'm very specifically saying interferon or lamivudine or adefovir, because at the time of the construction of this tape, that is the standard of care, and I will not say specifically combining them at this time. They are definitely combined for hepatitis C, because in hepatitis C it is interferon and ribavirin, and that is unquestionably combined. These drugs by themselves, ribavirin is completely useless and interferon is poor. So this is definitely combined. At the time of the making of this tape, interferon does not necessarily give greater efficacy when combined. Interferon or lamivudine or adefovir, A-D-E-F-O-V-I-R, adefovir. That may be a new drug for many of you. Lamivudine is one of the HIV medications. It was found by accident that people who had HIV who are getting lamivudine, also known as 3-TC or Epivir, that people who are getting lamivudine for HIV were getting their hepatitis B cured. So it not only acts as a contraceptive device for the HIV virus, but it also acts as a contraceptive device for the chronic hepatitis B, getting rid of the E antigen. Finally, alcohol. There is no specific test to diagnose alcohol, and saying, well, there's an elevated AST of greater than the ALT, well, that is drugs in general. And drugs elevating the AST in general, that's not just alcohol, that's any drug or toxin. There is no test to prove it. You exclude the others, and there's a bottle of vodka in their history. You exclude the others, and there's the toxin in the history. There is no specific therapy for alcohol-induced cirrhosis. You put them on a low Budweiser diet and hope it gets better. There's no specific therapy. If the liver fails, you transplant the liver if you can, and you're not one of the 5 to 6 people waiting for every liver that becomes available. You exclude the other causes, and there's alcohol in the history. What we have done is we have given something unique for each one of these in the history. This one is harder because it's only an itchy middle-aged female with an elevated alk phos. You can look for other history of other autoimmune diseases such as lupus or Graves' disease, vitiligo, pernicious anemia. Primary sclerosing cholangitis is the person with inflammatory bowel disease with an elevated alk phos, get an ARCP, and both of them are managed with bile acid binding resins. Hemochromatosis has the most unique presentation because in addition to cirrhosis, it causes cardiac abnormalities and it causes bronze diabetes, joint pains, infertility, skin color changes. Get iron levels and treat with phlebotomy if it's the genetic one from overabsorption. Wilson's disease has a movement disorder and psychosis. Sometimes Kaiser-Fleischer rings are visible to naked eye. Most of the time you need a slit lamp. You diagnose it with a ceruloplasmin level. All of them, the most accurate is a biopsy, except for the ERCP here. And you give penicillamine to bind the copper. Alpha-1 antitrypsin deficiency, look for the person with cirrhosis, and most importantly, emphysema in a young non-smoker. If they want to be kind to you, they give you the family history. Chronic hepatitis B and C, although we can look for a history of injection drug use, men who have sex with men, blood transfusion, needle stick, Many people who have chronic hepatitis B and C do not remember any exposure, and there's no identified risk in many of them, a significant percentage. Even nice girls can get chronic hepatitis C and not have a risk for it. You test for hepatitis B and C as a matter of routine. That is the only routine one in cirrhosis. No one is routinely getting an alpha-1 antitrypsin level. No one is routinely getting a ceruloplasmin level. No one is routinely getting the iron studies or an ERCP or the anti-mitochondrial antibodies. But you should routinely get the serology for hepatitis B and C in the evaluation of cirrhosis. Finally, exclude all of them as you need to and see alcohol in the history. You don't have to routinely exclude most of these things because there should be a clue to them. You don't have to routinely exclude all of them. You exclude these if the other presentations are there, and routinely exclude chronic hepatitis B and C. We take all the knowledge and try to make it small so it feels obtainable, so it can feel easy. There are the two things to make you move to study here. One is fear of failure. Oh my God, I'm going to fail step 2, I'm going to die. Or the people who want to get a 95 and thinking, oh my God, I'm only going to get an 85. Fear will drive you. The other thing is love, two things that will motivate you. So the other part of this is, let's get this to feel small, to see a world in a grain of sand, a heaven in a wildflower, infinity in the palm of your hand, eternity in this 1 hour tape in 1 hour. The other part is to say, gee, sometime I'm going to see some person, they're going to have one of these diseases. Maybe they have a treatable one that doesn't need a liver transplant, and unless I know this, maybe I am the only person who will know that I'm missing hemochromatosis, which can be treated with phlebotomy and not need a transplant. They won't die on the transplant list. Maybe it's possible that sometime you are the only one. Maybe there is no one else but you. Maybe the world will only be saved by your effort. Walt Whitman says, "Oh me, oh life, the questions of these recurring. What good amidst these, oh me, oh life? What good amidst these?" The question, what good? The answer, that you are here, that life exists, that the powerful play of life goes on, and you may contribute a verse. The powerful play of life goes on, and you may contribute a verse. Maybe you're the only one. Bye.